Please join me in welcoming our 3 physician assistants from the Ian Purcell Otoneurologist Group located in San Diego, Touraj Yari, Emily Jing, and Jake Perkins. Touraj Yari is a licensed physician assistant in California, completing his training at Western University of Health Sciences. Touraj has spent the last 9 years in the field of otoneurology by contributing to many of the protocols used in the clinic today with regards to vestibular testing, which has provided him a well-rounded perspective as a provider when approaching treatments of vertigo. He has traveled the world educating medical staff on vestibular dysfunction and looks forward to this in the near future, but currently spends most of his free time enjoying time with his wife and 15-month-old daughter. Jake Perkins is a licensed physician assistant in California who received his degree from USC. Jake specializes in otoneurology with a subspecialty in vestibular disorders, including peripheral vestibulopathies, which we will be discussing today. He just strives to continue to provide quality care for his patients and is proud to work with such a fantastic team of practitioners. In his spare time, Jake enjoys playing all sports and spending time with friends and family. Please mute your microphones. Thank you. Emily Jing is a licensed physician assistant in California who received her degree from UC Davis. She started her career in family medicine, where she spent 2 years treating a variety of medical conditions before transitioning to otoneurology. Now specializing in complex vestibular disorders, she enjoys being able to guide patients through the complexities of chronic dizziness and help patients regain function in their daily lives. Please join me in welcoming our speaker, Touraj Yari.
Thank you so much, Annette. We appreciate you guys for joining us this Saturday morning. Sorry the weather isn't a little bit better, but it's actually makes perfect for a good webinar. And we appreciate Annette and Longevity for helping set this up to give us an outreach to some of the people that they see that are afflicted by the disease. We also know that there are other participants here that are either family members of people that are suffering from chronic dizziness, or students or physical therapists that are also trying to learn and broaden their knowledge about how to deal with this condition. So we know how potentially debilitating this could be, and we are trying to hopefully provide as much education as possible on this subject so people can understand kind of the base foundational knowledge and kind of what we do here in order to help people. So we will break that down as we go along, but I'm going to go ahead and just jump into the content and go right into the little PowerPoint we have set up here. And let's get started. So we're going to go ahead and just start with evaluation of treatment of vertigo patients. So we are going to go ahead and discuss just an overview of balance, dizziness, and vertigo. And just kind of the concepts of what we mean when we say those words. When we say dizziness, sometimes it can be a little broad of a term, so we're going to try to break down the definition of what we mean. We're going to go ahead and go to different types of vertigo briefly, but our main focus is going to be chronic vertigo. There's a lot of more benign conditions that are, I think, more easily treated with certain maneuvers and treatments and medicines potentially. But I think the one major thing that we have in our clinic that shows up a lot is the chronic dizzy patient, which is a longer term relationship with us and the patient, because the recovery can be much longer than the traditional more benign vertigos that are a little bit more short term taken care of. So let's go ahead and see. Okay, so what do we mean by vertigo? So, I'll extrapolate a little bit more in the next couple slides, but in vertigo, what we generally mean is this sensation of movement, which can oftentimes be associated with a lot of other associated symptoms, including nausea, sometimes vomiting, sweating, malaise. Jake, who will be kind of going over, the expectations of what we see a person coming in clinically for chronic dizziness. We'll probably touch on some other symptoms, but just to kind of give you a potential extrapolation on that, there's patients that have cognitive issues because they're so dizzy. There's patients that have headaches and other symptoms as a result of their dizziness too, because it can be so taxing on their system, depending on how debilitating their vertigo can be. A lot of times when it comes to just the brass tacks of vertigo, the assumption is that there's some disagreements between your pathways that determine your balance, right? So to kind of give you an idea, basically the three major components of your balance, there's obviously more, I think, into the nitty-gritty, but the three major components of your balance are eyes, ears, and your legs, feet, basically. Your eyes, you have to basically see your environments. You have to perceive it in order to be able to navigate through an environment. That's why, obviously if you were to have eye issues like cataracts, things like that, it's understandable to have balance issues because you're not able to perceive your environment. Proprioception, which is basically, more the sensation of touch and feel, which is where the feet aspect comes in. Meaning that you have to feel your environment. You have to be able to touch and actually be able to navigate through sand versus rocks versus a solid floor versus an uneven sidewalk. Those inputs allow for you to be able to react with regards to your body in order to compensate for your balance. That's why, for instance, somebody who has like a neuropathy, like a diabetic neuropathy, which is numbness and tingling in your feet, can have less input, and so their balance can be compromised because of that. And then your vestibular system. Your vestibular system is your inner ear, which we're going to go into a little bit more detail, but your inner ear is kind of like your gyroscope. So think of it like an accelerometer on a phone. So when you are on your iPhones or any kind of tablets or any smartphones you have, when you flip your screen in the apps that allow you to do that, the phone has to know how you're holding it, orienting it in order to do that. And so there are these little accelerometers in phones that allow for you to be able to orient it based on gravity and where you are. So we have two of those in our system, which is our inner ears, and they kind of allow for us to be able to feel that kind of movement, even if our eyes are closed or if our feet aren't on the floor, right? Astronauts have a really tricky acclimation with this because there isn't a lot of gravity or momentum to help them with that orientation up in space. Let's do the next slide. So just to step back a little bit. So dizziness in general is kind of the broad term. We kind of think of ourselves as the dizzy specialists in town. When it comes to dizziness, it's all inclusive. Vertigo, as I mentioned earlier, is that sensation that kind of really is typified by movements, spinning, disorientation, that sort of thing. But a person can also come in and say they're quote unquote dizzy, but actually mean that they're feeling faint or they're feeling lightheaded, which could be from other issues that are not inner ear related, which we'll go over. Or they can come in and they say that I'm off balance. We get a lot of people that will come in and say, you know what, I'm not dizzy, I'm off balance. And that distinguishing feature or description can really help us determine what kind of workup or evaluation needs to be done in order to identify their particular source of dizziness or unsteadiness, in this case. Vestibular system. So the vestibular system, I don't want to get too much into the weeds, so I don't want, I know the slide's a bit busy. I'm going to try to break it down, in as much layman's terms as possible. But it's hard to, because it's such a very intricate and complex part of the body. It by nature has a complexity to it. But thankfully, we talk, ad nauseum with patients throughout the day. And so we've kind of figured out ways to kind of really describe the system in a way that's understandable. But it's, nice to kind of maybe go through the details a little bit so that you understand kind of what that thing does in order to find out what can go wrong, right? But the vestibular system really, the components at first are the inner ear, which, just to show you a little slide real quick, this is the inner ear, and you can see there like how intricate the structures are. You have the sections that deal with gravity, right? So being able to perceive movements in up or down fashion or forward, back, and sensors that allow for you able to to appreciate momentum in certain angles, right? So like, let's say if you have a roll or pitch when you head back and forth, or yaw, those are sensations that we can appreciate when we have movement of this structure, because the thing has fluid in it and it can help to move the sensors around in order for us to be able to appreciate that movement. This inner ear also includes the auditory cortex and the cochlea, which also help us with hearing. And Jake will talk later how important hearing and balance can be when they're happening either together or separately, because in this case they're so close and they're so almost entrenched together that it's kind of like thinking about if like your neighbor's house is on fire, then your house is on fire. So it's hard to sometimes see problems that only affect one particular distribution, but we do see that too. Let's go back. Okay, so inner ear. Then there's the vestibular nerve, which is this yellow bundle that goes back. The vestibular nerve carries all of the sensory information from the inner ear back to the brainstem. So in essence, that particular structure could have problems with it as well. You have the inner ear, which could have problems with it there, and then the vestibular nerve, which could have a problem with there. Tumors or other structures that are, putting pressure on that nerve that can cause an issue as well. But something has to relay back to the brain, right? So think of it as like a cable from a TV over to your receiver that, gives you all the information, all the channels, right? And then the vestibular nucleus. So a nucleus, just think of it, in layman's terms, as just a bundle of cells that are in a particular part of the brain where a nerve goes and communicates its information to, right? So if I were to tell Emily something here, Emily could be the nucleus. I have the information and I can relay it through her to her through the vestibular nerve, and then she can process it and then further disseminate that information to other parts of the brain and body that allow for the vestibular system to communicate with everything. So the nucleus can synapse and tell the thalamus, which is an area where you appreciate all of your sensory information, hey, my balance is off. I'm moving this way when I shouldn't be. It tells your spinal cord also what to do, because your spinal cord can talk to the rest of your body. And so if you're dizzy, you can react, assuming that you have some kind of balance issues. It also speaks to your eyes, which Emily will go over a little bit more detail later too, because your eyes have to be able to react to what you're doing with regards to your balance. And so those two systems are very much involved with each other as well. Let's go past this. So this is just a little shot. So, and this is not necessarily pertaining to chronic dizziness in particular, but just to kind of, I guess, illustrate how intricate this system is, there is a portion of the inner ear that houses these little things called crystals, or otoliths, rocks basically in the ear that are typically embedded into a part of the ear that allows for you to sense gravity. So think of it as like little rocks on your hair cells, right? And if you move one direction, the rocks will fall one way. And if you move another direction, the rocks will fall another way in order to tell you where gravity is. Those little things are extremely small. So this is an electron microscope picture of one of those shots where you're actually seeing a ton of these little rocks and crystals. But it just illustrates how complex the structure can be and all the potential problems that might lie there. So let's go ahead and talk about what we mean by peripheral versus central. This is important because we're going to focus on inner ear related issues clearly, because it's just something we see a lot here. Not to say that we see other conditions as well, but we're going to try to focus on the peripheral. But it's important to kind of know what we mean by that. So when we're talking about peripheral, we're talking about all the structures I was just alluding to with regards to the vestibular system. That includes the inner ear, the vestibular nerve, the nucleus to some degree. There's some cutoff, though, when it becomes the brain, which is the important part. But when it comes to peripheral vestibular issues, vestibular meaning inner ear, right? So vestibular meaning inner ear. When you have a peripheral issue, that means it's affecting that portion. That includes, like I was mentioning, those crystals. If they come loose and they go into the wrong part of the ear, that can cause a problem where you have a vertigo that's positionally triggered. There's potential issues with fluid buildup in the ear that can cause pressure in the ear. It can also cause dizziness as well. We're going to focus on something that results, unfortunately, into chronic dizziness, right? And that sometimes is an attack of either the sensors in the ear and or the nerve itself. Oftentimes, like referred to like a vestibular neuronitis. We're also going to talk about central really quickly here because it's important to distinguish that, because some people will have chronic dizziness, but it may be centrally more mediated, meaning it's brain and spinal cord. So think of it as brain, spinal cord. If you have a problem there, then it's technically considered a central problem, whereas if it's outside, which means the inner ear, it would be more of a peripheral problem. So examples of a central problem that can cause you to have dizziness or vertigo is a migraine, right? So there are types of migraines that can occur without a headache, and you can get just vertigo or dizziness in replacement of that feeling, and it can still be a central problem. Traumatic brain injuries or concussions can sometimes cause dizziness, among other things, as part of their symptoms, but that's a central problem because it affected the brain, it damaged the brain. Tumors and strokes are other examples where if you have problems with regards to the brain or spinal cord, it can cause an issue with your balance that's not an inner ear issue. So let's go next. Okay, perfect. So I'm going to go ahead and pass it along to Jake, who will speak about what happens when a person presents to our clinic with the complaint of I'm dizzy all the time, and how to go about evaluating and eliminating other possibilities in order for us to find the best treatment. So I'm going to pass it along to him.
All right. Thanks, Touraj. So let's talk. I usually term it kind of day one dizzy, right? When you're walking in the office, I'm feeling dizzy. As Touraj alluded to, we're going to focus a little bit more on the chronic dizzy patient. And as you can see on the slide, some of the terms for dizzy can be, I'm just feeling off all the time, cloudy, hazy. A word we use a lot of the time is boaty, floaty, kind of always sensing some form of motion in general. And that's one of the cues for us to clue in on is this an ear problem, right? And now, in terms of the causes of something like that, statistically speaking, one of the highest likelihood is, from a cause standpoint, is vestibular neuronitis, that there's some infection, some virus that got into the inner ear, damaged the sensors, as Touraj was alluding to. And the story from a patient perspective is typically more of acute onset of severe vertigo lasting for a few days in duration, not I got dizzy for a few seconds and I'm back to normal. It's a severe attack for a couple of days and you're starting to trend a little bit better, but you're still off balance. You're still boaty, floaty, foggy, that type of story. And that's what we're looking for from a diagnostic standpoint when we're chatting with you first day in the office to kind of clue us in on an inner ear problem. And some of the other symptoms we're looking for from patients is something called non-specific high gain head accelerations, difficulty kind of whipping your head around and that exacerbating your symptoms of dizziness. Something we call Costco syndrome, which could just be multiple visual stimuli. You're standing in Costco and there's a bunch of people walking by and it's just throwing you off. So we're looking for things that make your dizziness worse, right? Standing, walking, stress and fatigue can also do that. Typically, symptoms are a little better while you're lying supine and staying completely still, head neutral, not moving at all. But the second you're having some of these non-specific high gain head accelerations, you're bound to be a little bit off. From a diagnostic standpoint in the office, I won't get into the kind of the nitty gritty of this, but these are a few things that we're looking for from a testing standpoint to look for something called smooth saccades pursuits. Follow our finger. Are your eyes responding appropriately to movement? And those eye movements are driven by your inner ear. And we're going to talk about this infrared oculography here in a moment. That's going to help us, especially in more of an acute standpoint, diagnose more of an inner ear problem. So one of the ways we do that is with this chair, which I'll talk about in 1 second. But let's talk about a few of the other things that I'm looking for day one in the office. One would be in some form of imaging, an MRI brain. Those letters IAC stand for internal auditory canal. All we're looking for is thin cuts through the middle ear, looking for a tiny little tumor that could be hanging out on the nerve, as Touraj was talking about before. So that's one thing. The other thing I want to hear is that we've had a recent hearing test at some point, because the hearing center in the brain is about 1 millimeter away from the balance portion. And to say we've affected one without affecting the other, we can't confidently tell you that until we've evaluated for that. The testing we do in the office would be this infrared oculography, potentially something called a VNG and VEMP, which we'll talk about, and then metabolic workups, because sometimes we can have autoimmune inflammatory processes going on. It could be a vitamin deficiency, things like that are causing you to be a little bit off balance. So let's talk a little bit about the diagnostic portion in the office. For us, we're fortunate enough to have what's called an Epley Omniax chair. There's Dr. Purcell there. And here's a few shots of it. But basically, we put you in this chair and get you kind of strapped down there. It looks like a little flight simulator. But what it allows us to do is take gravity out of the equation. Right, we're able to put you in multiple positions anywhere we want and evaluate your eye movements. And so you'll be wearing these, this infrared oculography you're wearing goggles effectively. And one of them has an infrared camera on it, and we're looking at your eye movements. So just to touch briefly on the crystal portion, which is not our focus today, but what this chair is designed to treat. Somebody with crystals, inner ear crystals, BPPV, is going to tell that story of, I'm getting really dizzy for a few seconds, I'm back to normal in between these episodes, and then specifically, typically lying down, rolling over, room spinning story. That's a classic BPPV story. Let's put you in the chair, let's take a look, right? So we lay you on your back, we roll you one way, we roll you the other way, and we're seeing how your eyes are responding to those positional changes, okay? And on an oculography recording for crystals, I'd be expecting some form of torsional movement or a particular pattern of lateral beating based on what side we're laying you on. That would indicate that you have crystals. Now, somebody with chronic dizziness, we're looking for a separate set of lateral beating called sustained lateral beating, in the sense that no matter where I put you, whether it's laying down on your back, on your side, your eye is beaten in the same direction every single time. So let's go ahead and, there's Doc again with a few of these other, the chairs there. I just want to play a video for you. Once again, this is for someone with chronic dizziness. Now, when we look at these recordings, we're looking in detail at your eye movements. Now, somebody with a sustained left beating nystagmus, there'll be a slow phase of the movement, and then there'll be a fast phase as well. Now, somebody with a left beating, which is what we're looking at here. Now, mind you, this is to the patient's left. As we're looking at it, it'll be to the right, this fast phase movement is actually indicating that there's weakness on the patient's right ear. And that's where we would question, is there damage to one side or the other, in this particular case on the right side, based on the little video here. So another tool that we use in the office is something called a CDP, And this is more of a more for balance. This was actually designed by NASA, and it's to essentially allow us to evaluate where imbalance is coming from. Is it visual in nature? Is it vestibular in nature? Is it structural? We have an orthopedic complaints, those types of things. So that little board right here at the bottom is going to move a little bit. The background will move a little bit. We'll have you spend some time with your eyes open, with your eyes closed to try to help us diagnose that. Now, the last thing here when we talk about chronic dizziness is a study called the VNG and VEMP. These are two separate studies. They typically take about an hour, hour and a half in duration, and there's a lot of detail that we could talk about with this, but we'll kind of keep it kind of broad strokes today. But basically what we're looking for with this study is the same thing we were talking about over on the chair with this sustained beating, is where is their weakness? Is it on one side, is it on the other, is it on both? And the way we're going to evaluate that is with this study, and we'll focus a little more on what we call a caloric study, where we're heating up the ear and cooling it down. You can see our employee Evan there, and maybe a longevity faithful in there as well. But the result of this study is actually, the caloric study is actually shown on the screen here. And I want you to focus on the little bar graph in the bottom left. And that's a bit of the data that we're getting to say that this right ear, the number is, I believe that's 25 and 30 on the screen there. That's the response that we're getting while we're warming up the ear and cooling it down. And that's a pretty good response from both sides. But we're effectively comparing your right ear to your left ear and saying, are they the same? And in this particular case, they're not. And you see on the bottom right, those two little lines are kind of crossing over. And we typically want that to be in this little white box here. And you can see how it's just a little bit outside. That is the threshold that we're looking for, which is typically about what we call a 20% asymmetry, is kind of the entry level to say somebody's got a damaged ear that's shut down and we need to kind of further evaluate for chronic dizziness. And that's effectively what this test is looking for, and helping us get some definitive data where we can say this is an ear problem effectively. So I'm going to pass it off to Emily here, and we're going to talk a little bit about the treatments that we go into with the patients with chronic dizziness here. Okay.
Hi, everyone. Alrighty. So the treatments that we do for dizziness, of course, after all this workup, is to treat any underlying issue that we identify. So whether that from an MRI we identified a tumor, an old stroke, or if there's underlying autoimmune, inflammatory, or migraines contributing to that, we of course treat that first. Cardiac arrhythmias, other etiologies that we identify in the diagnostic workup. But if it does come out to be this peripheral vestibulopathy or an inner ear disorder, we of course treat that with some vestibular therapy. So these pictures here are just other etiologies that can result in a peripheral vestibulopathy. So Meniere's disease, if we have chronic Meniere's disease, the endolymph can fluctuate and cause a unilateral chronic vestibulopathy as well, in which a patient may complain of, always feeling off their game and off balance. An acoustic neuroma. So this is a tumor of that internal auditory canal. And Touraj had brushed up how, things in the brain or structural abnormalities are considered a central cause. But if you have a tumor such as an acoustic neuroma in the vestibular system, that we also treat as a peripheral cause and treat with vestibular therapy as well. A cerebellar stroke. So the cerebellum here is the area of that stroke, and that can cause issues in the peripheral system as well. You can see here on left side here, patient's right, this is the cochlea and the semicircular canals that Touraj had some pictures of earlier. And this stroke with all the edema and all can affect that peripheral system. And so patients can, with all these different conditions, can present with similar symptoms, which is where vestibular therapy can help. A Chiari malformation is a little bit different, but you can see the cerebellum, which again helps coordinate our balance and movements, is herniating down into our spinal cord there. And similarly, we treat these a little bit different, but in the end, we are trying to regain patients' balance, help them create different mechanisms so that way they can go about their days not feeling so dizzy. And then the last thing I do want to just briefly touch up on is iatrogenic. Iatrogenic meaning medications. Almost all medications have a side effect of dizziness, and the more medications we add on, the more things can result in dizziness. And so we always are taking a look at that as well to see if there's anything we can remove that may be a contributing factor. But when it all boils down, for a chronic vestibulopathy, our mainstay is aggressive vestibular therapy. And the main focus of this is on the visual vestibular stabilization protocols. And these all help us to recondition the brain to feel a bit more balanced. And I'm going to brush up on something called the visual-ocular reflex. And this is a reflex that we have similar to our knee-jerk reflex, but it helps us to associate our eye movements with our vestibular system, which is why so much of our vestibular therapy is focusing on head movements, eye movements to help stabilize. The eyes help the vestibular system sense where we are. The vestibular system also tells the eyes in which ways that we can help compensate the movements. And so these types of signals is what we're really focusing on in our therapies. One thing I want to go back and brush up on is that in the rare cases of a patient who is chronically dizzy that is refractory to certain protocols, there are certain medications. SSRIs help boost serotonin in the body. Low-dose clonazepam is also something that we use at times for those chronic patients. But a couple of things that we like to do is to send to our trusty vestibular therapists who have various tools that they can use to help our patients regain their balance, their proprioception. This is a Force Dynamics 301, which is a chair that patients can sit in, and they're getting vectored in all sorts of ways. And this is an Ultra G treadmill, which our longevity physical therapists do have, which is amazing. And then this is a spine force. So these three different tools are utilized so that way we can address treating dizziness in all of our patients, because we can't expect all patients to, not have knee problems or, other orthopedic complaints where they may not be able to put bear weight on their extremities and go through the protocols and be safe while doing so. And so these are ways that we can train the vestibular system, regain that strength in safe ways. And if we can advance our patients, then the goal here is to perform some high-end vestibular exercises where you are, let's say, walking on a treadmill, a Stairmaster, elliptical, or a rowing machine. And the goal is to utilize those eyes and move the head in various ways. Let's say on a rowing machine, you're moving forward and backward as the head is naturally moving, focusing on a dot in front, whether it's a magazine or, a Post-it note, and holding still while focusing. So that's training the eyes through that vestibular-ocular reflex to strengthen the inner ear. And then when you finish, 5 minutes of one certain gaze, you turn your head, focus again on a different location. And these are all different ways, again, that we're vectoring out that vestibular system and utilizing the eyes to build that back up. Our end goal is, of course, to make sure that patients can feel safe, walking, doing their daily activities, and going back to their hobbies. And some really great sports, actually, that are vestibular training are hiking, tennis, racquetball, trail biking, and pickleball. All, as you can imagine, you're moving against gravity in different various ways, focusing on one point of contact, and that is a great way that we just can make patients feel better with different exercises. So that concludes our presentation here. So I'm going to pass this back to Touraj.
Yeah, thank you. So yeah, in summary, I think the takeaways are, in order to have a great, successful encounter with a patient with regards to, dizziness, is have, somebody who has a good foundation of knowledge about what balance problems exist and how they are evaluated. Having a good, comprehensive, thorough workup, because you don't want to be fooled into thinking that something is a benign thing and not, delve deeper and make sure that it's not something that's more sinister. And then having the right kind of treatment protocols in place to allow for the patient to succeed. And a lot of it, as Emily was saying, revolves around conditioning, revolves around making sure that the patient has an environment to be able to focus on what makes them dizzy in order to strengthen that problem with their balance. And that's, I think, the key ingredients for being able to approach a chronic dizzy patient and having them recover. So yeah, that's the rest of our presentation. We're going to go ahead and just pass it back to Annette and hopefully, be able to answer some of your questions if you have any. So I'm going to stop sharing, and I think it's back to you, Annette.
Can you see me?
I can, yeah.
You can? Okay. I had a little bit of a technical glitch earlier, so I just wanted to introduce myself, that I'm the marketing coordinator for Longevity Physical Therapy. And Longevity Physical Therapy is a team of compassionate individuals looking to help you move better and live better by addressing your movement challenges, providing an excellent and individualized physical therapy. And with this education series, we strive to deliver a variety of clear and concise health information to help you live your best 2021. I did want to remind you that the information shared today is not to be used as a substitute for professional diagnosis, treatment, or advice. Always seek the guidance of your physician with any questions you may have regarding your health and conditions. So we'll be saving 15 minutes to answer any questions. So you can put them in the chat box if you like, and then we'll read them off to our therapists. And at this time, I'm going to stop the recording.